Good morning. How's everybody? Woke up, you hear my sleepy voice? I got to get it out of me, more hot tea and I'll be there. People are still coming in, but we're going to go ahead and get started. We've got a schedule. We got a full day. So my name is Mike Brose. I'm the Executive Director of the Mental Health Association, Oklahoma. If you remember last year from this very podium, I made a big announcement that we were going to change our name. We did it, and we are statewide now, and you're a part of that, and we greatly appreciate you all being here at the 20th Annual Zarrow Mental Health Symposium. You had not had a chance to look in the on-site program. It has the list in there. You can find it, the title of all the different 20 years of the symposiums. And if you look at that, because we've always tried to take on and been willing to really look cutting edge, think ahead, try to see over the horizon, take on difficult issues, not be afraid. So in your continued presence and support and your attendance every year is allowed us to continue to do that, and we greatly, greatly appreciate it. This is day 2. We hope you've enjoyed your breakfast, generously sponsored by the Oklahoma State Department of Health. If you've not already done so, please remember to sign in at the registration desk. We also ask that you sign in at each breakout session you attend. This is especially important if you are requesting CEUs or CMEs. Just one quick note. Yesterday, if you were here in the morning, one of our camera people had a little event, and she fainted, and it scared us all to death. But we want to report that she's doing fine. Tessa, and matter of fact, she's back there on the camera today. Wave, and let's give her a hand. So, Tessa, we're all relieved that you're good. So there's a lot of ways to get in front of the camera. See. That's kind of a hard way to do it, but all right. So we're glad you're good. Okay. At this time, I'd like to introduce my friend, Commissioner Terry White. She's, if you live here in Oklahoma, you have in our commissioner of our State Department of Mental Health and Substance Abuse Services, like I do, that we have an incredible friend, an incredible advocate, is our director. And I'm old enough. I've been around long enough to know that it hasn't always been that way, in just complete full candor. But Terry White, Terry Klein before her, and now Terry, we've got an advocate in our commissioner, and we're very thankful about that. Under her direction, the department has become nationally known for its children's behavioral health services, community-based treatment programs, technological innovations, especially telepsychiatry. For those of you who work out in our rural areas of Oklahoma, you know how important that is. We have a shortage of psychiatrists. We need that telemedicine. We need to find all kinds of new ways to use technology. Terry has been a leader and innovator in that area. And also integration of behavioral health care into primary care settings. Of course, next year's symposium is going to be very focused on that even more so. We appreciate Commissioner White's leadership, and we greatly appreciate her longstanding collaboration with all of us here in her support. The members of the Human Resource Development team are integral partners in this conference. So we're lucky to have our friend Terry with us, and she's going to introduce our keynote. But I want you to right now just join me in giving Terry a really warm welcome she so richly deserves.
Good morning. How is everybody this morning? For those of you that got to be here last night, isn't it amazing that we're at 20 years of the Mental Health Association, or more than that for the Mental Health Association, but 20 years of the Zarrow Symposium, and how fortunate are we to have leaders like the Zarrow family in Tulsa that have made mental health such an important cause for so many Tulsans and made amazing organizations like Mental Health Association of Oklahoma possible. So I know that they couldn't be here this morning, but I think it's worth giving a round of applause to the Zarrow family. There aren't many diseases where, because you have a disease, you're likely to end up in handcuffs, in the back of a police car, in a jail cell or in a prison cell, as opposed to a medical facility. There aren't many diseases that when you can't find services, you may lose your children. There aren't many diseases that are causing emergency rooms to be backed up the way that they are, because sometimes those emergency rooms don't have any idea what to do with the disease in front of them. And they're waiting for someone else, for us, to take this individual into our system to treat their disease. There aren't many diseases when you're trying to find someone help. You lead to a revolving door of services, you making calls, desperately trying to figure out what number you're supposed to call. If you're someone who isn't connected to our field, you have no idea where to start. There aren't giant signs around mental health and substance abuse the way that there are for other diseases. We don't have brand new centers for mental health, although we're making progress, where we have very well-known family names on the building. We've got an issue where, with most diseases, you can access care. If I was wearing a pink ribbon today, you'd know why I was wearing it. We don't have a ribbon that when I wear it, you know that the most important thing I think we can do for the overall health of this state in every aspect is address brain health, because the brain is the most important organ in the body and tells the rest of our body exactly how to function, and if it's not healthy, there's not a chance that we're going to be healthy for the rest of our body. I would think everybody in Oklahoma would find this outrageous. I know that many of you in this room do, but we still have far too many Oklahomans who don't understand what this issue means and why this disease is the most critical disease, mental health and addiction, brain disease, facing our state. Maybe this would be the case if it was cancer or heart disease, but we're talking about mental illness and addiction, which ironically is more prevalent than cancer, diabetes, stroke, or cardiovascular disease in our state. It's more prevalent than all of those diseases. For decades, we've swept brain disease under the rug, not even talked about it as what it is, a disease of the brain. Yet, we've completely made different progress as it relates to other issues. The day that all women wear red, we wear that for heart disease. That day, usually on a Friday, we all know what we're talking about. We haven't gotten there yet with brain health. But science has. Science is also showing us our approach to these illnesses may not have been the most effective in the past, but we're learning every day amazing new issues, causes, biological bases, and what's literally happening in the brain around our brain chemistry that relates to these diseases. We have more than 40 years of prevention science, and I'm thrilled this year that the theme is prevention, all things prevention. We have more than 40 years of prevention science, not wanting to prevent, not daring kids to say no, which didn't actually work as many of you remember, but actual science around prevention. And a lot of that's science around the community level and what we can do in our communities. The same way if you think about heart disease, we know if we exercise, if we don't smoke, we can do those things around prevention. But there's this other exciting area of prevention too, and that's the science of what's happening in our body. The same way that we may be genetically predisposed to heart disease, we may do everything right and still have high cholesterol. You're going to get to hear this morning from a speaker who's going to talk about the science around what's happening in our body as it relates to early psychosis, first breaks, how we intervene very early on to prevent this disease from progressing, to prevent potentially full-blown symptoms from developing, which is an incredibly important part of what we're focusing now on in our state, setting aside 5% of our block grant to work on early intervention science and prevention. Risk factors often exist in clusters rather than isolation. We know that. But science is teaching us some valuable lessons of actually how to intervene. Progress has been made, but progress cannot come quickly enough. Progress has been made, but progress cannot come quickly enough, especially for 1 in 4 Oklahomans who is struggling and their families who are desperately trying to have someone address this disease of the brain so that their loved one can survive for the next 32 years. Because in Oklahoma, The national study that came out said that people with untreated mental illness lose their lives 25 years earlier than the general population. In Oklahoma, if you have mental illness and addiction, and they often go hand in hand because it's the same organ in the body, we lose over 30 years with our loved ones, with our friends, with our coworkers, with fellow citizens. We take a lot of pride in our state for being recognized for doing some amazing things. You all know me a little bit, and I'm not a huge sports fan, or not as knowledgeable about sports as I should be, but we know that, or I could be, I should say. We know it's football season, and everybody's waiting to see how OU and OSU are going to do in football. We know that soon, which I do know a little bit more about, it's going to be basketball season. And particularly if you're from the metro area, but all around our state, we have a whole new excitement around the Thunder. We want to be number one in these things. We're number two in something in Oklahoma. We're number two for the number of people in the United States struggling with mental illness. Oklahoma has the second highest rate of mental illness of any state in the nation. We have the second highest rate of mental illness in any state in the nation. On any given day, we have about 21% of our population struggling with mental health issues and about 12% of our population struggling with addiction issues. But what that means is we're talking between 700 and 950,000 Oklahomans. Because a lot of times we use percentages. And about a year ago, I started using the number, because when I started saying that out loud, even to me, and this is now my 8th year, it felt very different. We're talking about 700 to 950,000 Oklahomans. We know the consequences of not providing treatment. We know that people may end up in a situation where they find themselves unemployed. They might find themselves homeless. They may have struggled with addiction because they couldn't find treatment for their mental illness, or vice versa. And ultimately, we end up in a situation, as we talked about earlier, where people are more likely to see the inside of a jail than a medical facility. And the ultimate consequence, we may lose people who die by suicide, who die from overdose, or who die from all of the other health conditions they're struggling with because they didn't have good brain health in the first place. We know that if we're going to address the cost to our communities, and more importantly, making sure that every Oklahoman has an opportunity for good health, we've got to change the way we address brain disease. We know that substance abuse and mental illness can be treated. They can actually be more effectively treated than many other diseases. But somehow the stigma around these diseases prevents people from thinking that or understanding that or considering that. We know that half of our adults who are struggling with mental health issues had the first onset before the age of 14. First onset before the age of 14. And when that happens, as adults, they're more likely to experience alcohol and drug abuse, difficulties with employment, depression, and thoughts of suicide. We know, however, thinking about prevention, the risk factors for developing these diseases, the risk factors are often there 2 to 4 years before the disease actually develops. So there is a time to intervene. That's the good news. There is a time to intervene very early on and to actually move. And I say move, we can't forget the dialogue we've got to be having about we have so many people struggling who aren't receiving treatment. But we can actually move to the dialogue about also, at the same time, really focusing on early intervention and prevention and preventing this disease from becoming a full-blown disease for people in the first place. And I think that's really exciting because the fact is we're never going to have enough resources for all the devastating things that happen when we leave people with untreated diseases for between 6 and 23 years, which is about, it's the actual average, which the average to me is shocking because it's so broad. But even at the lowest end, 6 years between the time a disease starts and someone gets treatment when it's mental illness. On the high end, it's 23 years between the time the disease starts and someone actually gets treatment. So thinking about being able to do early prevention and intervention, can you imagine if we could slow down the number of people at our doors, the number of people desperately trying to get in? Because we only can reach, all of us can only reach 1/3 of Oklahomans who are struggling. 2/3 of Oklahomans who need help for their mental illness and addiction are going without it every single day in our state. So if you can imagine what it could look like if we could intervene earlier and actually do prevention. We're doing everything we can. I know that you all are doing everything we can, and we are making progress. The fact that we had so many people here for this conference and for the discussion last night. The fact that, unfortunately, if you see me step out for a few minutes, I apologize, I will be right back. But we actually have a major media outlet that wants to talk for a few minutes to cover the fact that we're talking about this issue today. Think about how different the coverage is on this subject than it was just a few years ago. So we are making progress. Today's workshops are going to provide plenty of information about prevention and other important issues in the field of behavioral health. So I really hope you'll take the opportunity from this symposium to apply what you learn in all of your communities, all across the state, because we know, and you know better than anyone else, prevention and treatment really work, that recovery happens every single day in Oklahoma, and we have hundreds of thousands of people leading full and productive lives here with us helping run the conference today, raising families, leading companies, being productive members of their community. It's just that we have to continue to scream about the brain science so that it's not just hundreds of thousands, but it's every single Oklahoman who struggles with a mental illness or addiction. Thank you very much for having me here this morning. It's now my honor to introduce our morning plenary speaker, Dr. Amy Goldstein, Associate Director of Prevention and Research for the National Institute of Mental Health. The Mental Health Association is proud to be a longtime NIMH outreach partner here in Oklahoma. This conference is one of the ways the Mental Health Association of Oklahoma is working to help increase the emerging knowledge and help translate science into service in our state. In October 2013, Dr. Goldstein was named as the NIMH Associate Director for Prevention. In this congressionally mandated position, she collaborates with other NIMH divisions, other NIH institutes, other federal agencies and external organizations to build and manage the NIMH-wide Integrated Prevention Research Program. This morning, she'll be sharing information about the landmark RAISE study and exciting developments related to the prevention and early intervention of psychosis. Please join me in welcoming Dr. Amy Goldstein.
As I fall up your stairs, thanks. Let me just grab this. Thank you for that introduction, and thank you for inviting me to Oklahoma. I've actually never been here before, and this was a great excuse to come, although unfortunately I'm only here for less than 24 hours due to flight delays. But your airport and hotels have been lovely, as have all the people I've met. So thank you again for inviting me. I just want to take a minute to acknowledge my collaborators back in Washington on the RAISE project, which is what I'll be spending a lot of time talking about today. They couldn't be here today because they're actually at another meeting talking about how to establish national networks of early psychosis intervention and treatment centers, so another kind of exciting development. But that's Dr. Bob Heinsohn, who's the study director for the RAISE project, and Dr. Susan Azrin, who is one of the program officers for the project, and I serve both as the associate study director as well as a program officer. So just two standard disclosures. I have no personal financial relationships with commercial interests relevant to this presentation, and the views I'm going to express are my own. I feel like I should add a third disclosure to this list, and that is I am in fact expecting a baby in January. I say this for two reasons. One, I just learned you had a fainting yesterday. You will not have a delivery this morning. I promise you that. I still have a couple more months to go. But also, standing for long periods can get wearing on my back, so I might sit down for the Q&A if I can't last as long as I need to be standing. So you'll forgive me for that. It's just to save my back for the day. So now let's get to the business of what I'm here to talk about today, and I think your commissioner did a great job of framing what at least a lot of what I'm going to be covering with respect to background. I'm going to give you a bit of an overview just of schizophrenia in the course of the illness. I'll talk about the rationale for early intervention in psychosis and why it's so important, and I think you just heard a very wonderful talk about why it's so important to intervene early. I'll spend a lot of time talking about the RAISE initiative, or Recovery After Initial Schizophrenia Episode, which is a large research project launched by the NIMH 5 years ago to try and address this issue. And I'll be presenting a coordinated specialty care model. So this is what we really believe to be kind of the gold standard or evidence-based practice that would best serve in early intervention for psychosis. I'll talk a bit about financing or approaches to getting some of these services paid for, and then the next steps for the NIMH, at least in this space of early intervention for psychosis. So by way of background, I thought I would spend a minute or two on framing the motivation for this increased focus, at least on the Institute side, on early intervention in psychosis, although for better or for worse, the reason might be obvious to everyone in the room. And this really comes from a response to incidents of mass violence in the United States. Unfortunately, there have been way too many incidents of mass violence in the US in recent years. We in Washington just had the 1-year anniversary of the DC Navy Yard shootings. There's been Virginia Tech, Tucson, Newtown, Sandy Hook, Aurora. I mean, unfortunately, the list goes on. And oftentimes, once you hear about these stories and the stories of the individuals involved unfold, what you hear are stories of mental illness. You hear stories of individuals who might be suffering from psychotic symptoms that have never been treated. Or in the case of Virginia Tech, you hear the story of somebody who had been in and out of treatment and fell through gaps in our mental health treatment system. And unfortunately, we have these tragedies in the United States as a result. So following the incident at Sandy Hook, there were 23 executive actions and recommendations coming from the White House on how to address issues around guns and gun violence. And from the Department of Health and Human Services perspective, the focus became increasing access to mental health services. So how do we make evidence-based services more readily available to those individuals in the United States who need them? And from the NIMH perspective, we really decided to tackle this question of early psychosis. And we launched an initiative that we call EP3, which is Early Psychosis Prediction and Prevention. And it's really a large-scale effort on our part to both figure out for individuals who are experiencing their first episode of psychosis what the best evidence-based care is for them and how do we get them into care. And then for individuals who are at high risk, how do we improve our capacity for early detection and intervention? So both to kind of increase our efforts in the high-risk space, so individuals who aren't diagnosed but at very high risk for psychosis, and then for those who have already experienced psychotic illness, how do we improve their services as well as their access to services? And the EP3 initiative is very broad, and it spans everything from basic brain and behavioral science to dissemination, implementation, and policy research. So a little overview of schizophrenia, although none of this information might be new to individuals in the room. About 2.5 million adults in the United States are affected by this illness, and the onset is typically in late adolescence or early adulthood. So I'm differentiating this schizophrenia from the childhood onset schizophrenia, which tends to be a little bit more severe and retractable. And there is a high morbidity and mortality associated with this illness. So the typical conceptualization of schizophrenia in the United States, at least when the RAISE project was launched, is that it is a chronic disabling condition that you do not recover from. That's it. You get this illness and no job, no future. And unfortunately, that's something we want to change because there's multiple episodes of psychosis over the lifetime. Individuals have a psychotic episode, they might go into treatment, and then they might relapse, so it's chronic. There's high unemployment, homelessness, and incarceration associated with schizophrenia. So about 80 to 90% of individuals with chronic schizophrenia can be unemployed, 20% can be homeless, and 17% live in jails or prisons. So I think the lunchtime session will be talking a lot about this, but how our justice system has become a de facto mental health care system because of this high comorbidity between individuals who are mentally ill who end up in the justice system. There's a shortened lifespan associated with individuals who have schizophrenia or serious mental illness, high rates of suicide, especially during the first episode of illness, and many, many medical comorbidities, either from engaging in unhealthy behaviors, illnesses caused by the psychiatric disorder itself, or again, engaging in just high-risk behaviors. And finally, schizophrenia can be costly. This is data from 2002, but the economic cost, the estimate of cost of schizophrenia in the United States was $62.7 billion. And the direct healthcare costs were $22.7 billion. So only 1/3 of the cost of the illness was actually due to the illness itself, and 2/3 was the societal cost. So anything from caregiver burden to lost productivity at jobs, to the homelessness, to the incarceration. So this is just, in general, a very costly illness to the individual, their family, and to society as a whole. So this is just a graphic of what the course of the disorder looks like in its usual form. You have a period of premorbid functioning where everything looks pretty good, although there might be some non-specific precursors to an illness onset. So maybe some subtle deficits noted in early childhood, maybe some motor delays, some social impairments, or some cognitive deficits. And then the individual enters what's called a prodromal phase. So this period, the prodromal phase, or the terminology shifting to calling individuals at clinically high risk for schizophrenia, is a period well characterized in the literature where there's kind of some subthreshold or attenuated psychotic symptoms. So you kind of start to see functioning decline, and psychotic symptoms start to pick up. So these might be some cognitive deficits, some affective symptoms might be displayed. You know, if you're dealing with an adolescent, there might be a drop-off in school performance, some social withdrawal, less participation in activities with peers, just a general decline in functioning. And what we see from research that we funded in this period is about anywhere from 30 to 35% of individuals who are characterized as being in a prodromal phase of psychosis actually go on to convert, to develop a full-blown disorder. So not part of my talk today, but we do have a lot of research going on to better identify which individuals who are in that prodromal space are more likely to convert to a full-blown psychotic disorder, again, so that we can intervene early enough to prevent that psychosis. But in the typical course of the illness, basically, eventually what happens is the psychotic symptoms become more prevalent, functioning declines, and an individual enters an active psychotic phase of illness. And this progressive phase can be of variable duration, but typically what you see is somebody might have psychotic symptoms, they might engage in treatment, and then they feel like they're doing better, so they stop participating in treatment, and then they have a relapse, and then this cycle continues over the course of time. And then eventually there's a residual phase of illness where symptoms and functioning generally plateaus, and what you see from this graphic is that functioning never gets back to its baseline level. So the individual for the rest of their life ends up with some level of impairment or disability. And what we see from the research literature is that most of the disability that's going to accrue from schizophrenia happens within the first 5 years of the illness. And that's one of the reasons why early intervention is so important. It's because if you want to stop that disability from happening, that individual must get into treatment earlier on, because that's when our treatments are more effective. But unfortunately, as was noted, treatment delays are common. Typically 1 to 3 years, at least in the United States, are the delay between symptom onset until the time that an individual actually participates in care. This concept, this delay, at least in the research literature, is called the duration of untreated psychosis. So that's the interval between the onset of psychotic symptoms and the initiation of antipsychotic treatment. The bar is antipsychotic treatment is the criterion standard, and basically meta-analyses relate longer DUP to poorer response to medication. So the longer an individual goes suffering with their symptoms, the less effective the medications are going to be once they're actually delivered, and poor symptomatic and functional outcomes. So again, the longer an individual is suffering with their symptoms, the less likely the interventions that we have are actually going to be effective. And unfortunately, in the United States, DUP is very long. So this is a summary of studies, about 6 studies representing about 558 participants between 92 and 2003. And what you see is the average duration of untreated psychosis in the United States was anywhere from 61 to 166 weeks. So anywhere from 1 to 3 years of an individual suffering with active psychotic symptoms that is not engaging in care. And then we have more recent data. This is coming from one of our RAISE studies. And we see from 2010 to 2012, the median duration of untreated psychosis in the United States was 74 weeks. So this is 404 clients across the United States, 34 clinics, 21 states. So you can see generally across the country, when we don't have specialty care programs, individuals go over a year of suffering with symptoms before they engage in any kind of a treatment program. So the question is, what happens if we reduce DUP? If we increase our access to services, if we can actually reduce duration of untreated psychosis, can we improve our outcomes? And we hope yes. So what we're trying to achieve with the RAISE project is to kind of drop this line down of early detection and intervention just at that point where that individual is transitioning into their first episode of psychosis. And this is what we're hoping will happen with trajectories. So we're hoping that with kind of more involved aggressive treatments earlier on in the course of illness, we can change the trajectory for this illness so that the conceptualization of schizophrenia in the United States is no longer one of a chronic disabling condition, but of a condition that you can recover from, and of a condition that can be associated with improvements in functioning, remission of symptoms, and increases in overall quality of life. So we know a little bit about what early intervention services should look like. So there's a wealth of information that's been of tremendous value and benefit to us here in the US and at the NIMH in thinking about early intervention care. And a lot of this work has been done abroad. So in the UK, Norway, Australia, they've really been ahead of us in terms of thinking about this concept of early intervention for psychosis and coming up with this idea of multi-component treatment packages. So we know that early intervention services should probably involve early detection and easy access to care. And that care should be youth-focused and recovery-oriented. So the one thing to keep in mind, which is a shift in some people's thinking when thinking about schizophrenia, is when you're talking about first episode, you're talking about a very young population. You're talking about individuals who are anywhere from 16 to 22 years old. And if you know anything about adolescents, these are individuals who are struggling with autonomy and independence, and they think they're invincible. So the last thing they want to be told is, you are going to be diagnosed with a chronic and disabling condition. So the goal is to try and create services that get rid of that framework and give them the hope and the promise of recovery, and the fact that they can be independent, autonomous students, employees, or whatever it is they're hoping to achieve in the world. So the keys are youth-focused, youth-friendly, and recovery-oriented care models. These are team-based and person-centered treatment models. So team-based means that there is not one clinician who delivers this service. The services I'm going to be talking about today are service packages that are delivered by multiple clinicians, and they're person-centered treatment models. So that means not every individual who's participating in this treatment program will be receiving the same package of services as somebody else participating in that treatment program. It's tailored to the individual based on their needs and based on their preferences. So it's a real shared decision-making model when it comes to thinking about what a treatment package could look like. And the services involve empirically supported interventions. So the key components are low-dose antipsychotic medications. So the notion with first episode care is to start low and go slow. So typically one medication at a lower dose is more effective with a first episode population than higher doses of medication or polypharmacy. Cognitive and behavioral psychotherapy has been shown to be efficacious. Family education and support, so really active engagement and involvement of family members, both to educate them about the illness as well as signs of potential relapse and crisis management. And then education and vocational rehabilitation. And I'll be spending more time on this later, but what we're finding with the RAISE project is having supported employment and education available to individuals is probably one of the most important ingredients in terms of engaging them into the overall care program. And these interventions are time limited, so they're thought to be about 2 to 3 years, and then an individual would step down into treatment as usual for ongoing maintenance treatment. So the goal is to reduce duration of untreated psychosis and to provide early intervention services to promote long-term recovery and to reduce overall disability. So early intervention matters. And I could spend a lot of time up here talking about why early intervention matters, but I'm going to let somebody else talk about why early intervention matters, and that is an individual named Ryan. So this is a video that was developed as part of the NIMH RAISE project. I'll let you hear from Ryan, and then I will talk a little bit more about this concept of early intervention. So could we show the video?
Hi, my name is Ryan. I'm 34 years old. I work full-time as a civil rights advocate for individuals with mental health disabilities in a state psychiatric hospital. I recently graduated with a master's degree. I happen to drive a nice automobile. I'm single, enjoy dating, and I'm also in recovery from a form of schizophrenia. Today I'd like to talk to you about how I returned to school. This is the picture of me when I showed up on the first day of classes to have my student ID taken. I'm overweight, disheveled, poorly groomed, and the thing that strikes me most about these pictures, in my eyes, I can feel what it was like back then. I can see the hopelessness, sort of despair, in the picture. I definitely wasn't happy. On many days, I sort of wished that life would just go away, that I were dead. It was too painful. One of my main fears was that I would never be able to work. This process of going back to school is a futile, being a person with a major mental disorder, to actually go through this process of going back to school. But I made the decision that I was going to go and study what I wanted to study and pursue my own education, actually, to pursue knowledge for knowledge's sake, despite the fact that I believed that I couldn't work. In the midst of that 7 years that I was in college, I was hospitalized at my most ill moment. I had teachers that were very supportive and allowed me to make up the work. And I was able to take incompletes for those semesters. The support of my family, friends, and my professors was enough when I was hospitalized to allow me to believe that that wasn't the end of the road. The stress of school never put me in the hospital. I'd say the stress of believing I couldn't achieve at school because I'm a person with a mental illness probably was more stressing to me than the stress of finals and final papers and things like that. I didn't think I was able to work, and so I didn't. It was sort of a self-fulfilling prophecy. After I finished my bachelor's degree, I worked successfully for a year before I started a master's program, and I actually completed the master's program in 2.5 years, which was the standard time as opposed to the extra length it took for me to finish the bachelor's degree. And I worked full-time and went to school full-time at the master's level and completed that in a timely fashion. From my experience, I guess I'd encourage anyone to go back to school who's thinking about it. It's such a crucial aspect of my recovery that I think education can be an arena where anyone can sort of discover who they are, discover what they're passionate about. And I'd say through the process of education, we sort of become more ourselves by learning what we're able to do. I guess I didn't know who or what I could be until I started learning exactly what I could do in the world and then doing it.
So that was Ryan, who is an individual in recovery, as he said, from schizophrenia. And he was not a participant in the RAISE project, I should say that. But the video that you just watched was created as part of one of the RAISE treatment studies. And there are a series of 24 videos. It's called the Voices of Recovery video series. They're actually free. They're available online. You can use them, you can download them, and there's a manual that goes along with them. But basically, they were created by the research team to be used, one, as a tool for engagement, so to show individuals that are trying to engage in their treatment program that this can be your story too, that you can have a story of recovery, of returning to school, of getting jobs, and of kind of leading the life that you want to lead, but also to help educate providers and clinicians that, again, this concept that schizophrenia doesn't have to be a chronic disabling condition, but that you can have really hopeful, promising stories of recovery and of returning to work and returning to school. So I've got, at the end of my slides, a link to the website where you could find this video as well as all the other ones, and I really encourage you to go and look at them and watch them. They're individuals in recovery, their families, just talking about their experiences. They're just unscripted videos of people talking about their lives living with mental illness, and I think they're really valuable tools to use, both for treatment but also for engagement and education purposes. But I think Ryan's video, I like to use it because it really illustrates this notion of recovery and why early intervention and engagement in effective services is so important. Just in terms of the data side of it, you can see with early intervention, you end up with rapid remission of positive symptoms. So about 85 patients with first episode of psychosis are able to achieve complete symptom remission within 6 months, most responding within the first month of treatment. With earlier intervention, we see lower rates of rehospitalization. So individuals might come into treatment programs through a hospital setting, but they're less likely to have to go back into the hospital if they're engaged in appropriate multi-component care programs. There tends to be decreased substance use improved social and vocational functioning, and overall increased quality of life. So, it's kind of the promise of these sorts of outcomes, which is why we launched the RAISE program as a way to study and test early intervention treatment models in the United States. And again, our hope is that we end up with many more stories like Ryan's, with individuals in recovery leading really productive, satisfying lives for themselves. So in 2009, the NIMH launched the RAISE project, which stands for Recovery After Initial Schizophrenia Episode. And there's kind of three main goals to RAISE. So we're focusing on indicated prevention, we're focused on interventions in community settings, and we're talking about interventions that are scalable. So, we knew going into the RAISE project that multi-component treatment packages for early schizophrenia could be effective. We saw this from abroad. We saw this from Australia, we saw this from the UK, and we saw this from Norway. There were two limitations there for us. One was that none of those programs had really been empirically tested with kind of the gold standard randomized controlled trial, which is what we need here in order to call something an evidence-based practice. The second challenge was all those programs were tested in healthcare systems that are very different than the US healthcare system. So we know that these treatment packages work, but the question was, would they work in our healthcare delivery system? And that was really the goal of the RAISE project. It was to take these multi-component treatment packages that we thought to be effective abroad and try to figure out how to make them work in the United States. So we did things a little bit differently with the RAISE project than you typically see with large randomized controlled trials that the NIMH funds. And by that, I mean we made some criteria very explicit in our statements of work and our requests for proposals. And one was that we didn't want these treatment studies to be done in academic medical centers. Oftentimes what you see with research studies is that the studies are done in really highly controlled environments with a very select group of patients, and you find a result from the study and then it completely doesn't translate into community mental health centers. So what we said was that in order to do this study and in order to participate in this study, the study has to be done in community mental health centers that are not affiliated with academic medical centers and don't have specialized treatment programs. So we wanted to develop and test an intervention in the settings in which it would ultimately be delivered. So we wanted our researchers to be able to come up with strategies for training real-world providers and how to deliver these services. And we also wanted them to figure out ways of getting these services paid for. Because again, what often happens in a treatment study is the service is paid for by the treatment study. Then the treatment study goes away and the service goes away. So our goal was to create interventions that could be disseminated and delivered in real-world settings and paid for in real-world settings, so that by the time the study was over, these interventions could be quickly taken to scale. And we wouldn't first have to stop and think about, oh, well, gee, how would this work in community mental health? Or, well, how will this work when you don't have somebody's doctoral level student delivering the intervention? So that was the goal of RAISE. So to develop multi-component treatment packages for first episode psychosis that could be delivered in the real world in community mental health settings and could be quickly taken to scale if they're shown to be effective. So we had two projects that we funded as part of the RAISE study. There are two goals for RAISE: improving clinical outcomes for patients, but also informing payers of what they could and should cover in order to avoid long-term disability. So we're hoping that the projects will generate information relevant to key stakeholders, so policymakers, clinicians, service users, kind of a whole array of stakeholders have been involved in the RAISE project. So we've got two studies that have been ongoing. The first is the large randomized clinical trial, and it's comparing the effectiveness of phase-specific intervention to usual care for first episode psychosis. So this has been a national study with 34 clinics across 21 states, randomizing the clinics to either deliver the specialty care program or to deliver service as usual. And this was a contract awarded to John Kane, Nina Schooler, and Del Robinson at the Feinstein Institute for Medical Research in New York. And they're focused, again, the goal with RAISE, it wasn't just about symptomatic remission, it was about recovery. So the primary outcomes that we're looking at in this study are recovery, so functional outcomes, quality of life, return to work, return to school, in addition to symptomatic recovery and improvement of symptoms. So they'll be looking at social, academic, and vocational functioning, as well as the overall cost effectiveness of this treatment program compared to services as usual. The second study we called the implementation study. So it's RAISE IES, RAISE Implementation and Evaluation. And this was a contract awarded to Lisa Dixon, Susan Essick, and Jeffrey Lieberman at the Research Foundation for Mental Hygiene in New York. And this is the team that created the video that I showed you earlier. But the goal of this project is to study the barriers to implementing this kind of a treatment program. So basically what they're doing are coming up with manuals, and they've come up with manuals that guide you in terms of how to set up referral networks and strategies for case finding, manuals for how to train and supervise existing clinical staff around these treatment programs. They've come up with financing models to support first episode treatment programs. So basically these two studies complement each other, where one is the large RCT looking at the overall effectiveness of the program, and the second project is they're looking at clinical outcomes. They're in two clinics, one in Maryland, one in New York, but what they're also doing is developing the manuals and tools that any clinic administrator could use in order to develop one of these treatment programs on their own. So they're really coming up with the how-to guides for how to set up these kinds of treatment programs, how to deliver them, how to pay for them, and how to train your providers. So this is just RAISE by the number. This is a United States map of all the states that have participated in the RAISE project. I'll apologize for the fact that Oklahoma was not a state involved in RAISE. I don't have the answer as to why. So the study teams basically had criteria that they were looking for clinics when they were enrolling clinics in the treatment study. But hopefully Oklahoma will get involved with the state mental health block grant funds and start implementing coordinated specialty care through that. But you can see we had two studies. They represented 22 states. There were 36 treatment sites, overall 134 providers, and 469 participants. So this was really a national effort. The large RCT wanted to get, as much representation as they could of the United States in terms of their participants enrolled to get, kind of a real representative sample. So again, we're looking at phase-specific specialty care for first episode psychosis versus treatment as usual. The patients, providers, and community clinics are all representative, so these are not specialized treatment settings that have already had experience with first episode psychosis. This was kind of general community mental health centers. We're focusing on clinical and functional recovery, cost of care, and overall societal benefit of this kind of a treatment model. And we've got some early deliverables coming out. So all of the participants in the study have been enrolled. They've all been receiving treatment for 2 years. The two research teams are working on their treatment outcome papers now, but things are looking really promising. And so far, we've got some early papers that are in process of being published that look at things like duration of untreated psychosis in the United States, so that data that I showed you earlier about the average DUP of participants participating in this study. We've got papers coming out on what baseline medication use looks like for this population. So for individuals who are coming into care, are they coming into care on medications that are kind of guideline concordant in terms of what we consider best practice, or is there a discrepancy between what should be prescribed versus what is being prescribed? And a paper on medical comorbidities in first episode psychosis. So some really interesting data looking at early precursors to metabolic syndromes and chronic health conditions that are in first episode psychosis patients. So what we're seeing from the data that's coming out of the study is that these medical comorbidities are seen very, very early on in the course of illness, which is arguing for even more of an increased collaboration between primary care and specialty mental health care in terms of managing both the psychiatric illness but also the physical comorbidities that arise as a result of the psychiatric illness. So I've been spending a lot of time using this phrase, coordinated specialty care. So what I thought I would do is spend some time unpacking it for you so you can kind of understand what it is that I'm talking about when we talk about coordinated specialty care for first episode psychosis, or CSC for FEP, as people like to call it. So this is a graphic that just kind of outlines all the different roles, the services that individuals provide, and the credentials that are kind of recommended for the individual who delivers the service. When we talk about coordinated specialty care, we talk less about numbers of people on a treatment team, and instead we talk about the roles that individuals fill. So this isn't the kind of a treatment model where you have to go out, if you're a clinic administrator, and hire 6 new people to fill these roles. There can be a lot of different configurations of how to set up these kinds of a treatment team. We at the NIMH drafted a white paper summarizing this treatment model. It's available on our website. But in it, we walk through different sorts of configurations. So for example, you can have a team leader who also delivers family psychotherapy. You could have a psychotherapist who also is responsible for case management. So there's lots of different ways you can come up with existing clinic staff configurations to implement this kind of a treatment model. But a lot of these roles are probably familiar to you if you work in clinical settings in terms of psychotherapy, case management, family therapy, and pharmacotherapy. So what I want to do, instead of talking about those, is to talk about the two that are a little bit more unique to this kind of a treatment program. And not only are they unique, but what we're finding is they're probably the key ingredients to making this kind of an intervention work and to its overall effectiveness. So I'll start with the team leader, because as I mentioned from the start, early intervention services are team services. It's not one clinician, one client, it's multiple clinicians and the client. And so the goal of the team leader, one of the unique goals of the team leader, is to cultivate referral networks and facilitate access to care. So what I also said at the start when I was kind of providing an overview of early intervention is that there's an active engagement. These are not the kinds of clinic programs that wait for somebody to come to them, but they actively go out into the community to seek participants or clients who might be appropriate for their services. So this is what current path to care tends to look like in the United States. You have the onset of symptoms. Then after a period of time, as we've already mentioned, maybe 1 to 3 years, somebody engages in help-seeking behavior. And depending on where they are in their life, that help-seeking may occur at the level of a school counselor, may occur in the physician's office, or the primary care physician, or a pediatrician. And then what you see is that individual then cycles through a system. So maybe they'll get referred to community mental health care, and then they might end up in a crisis situation. And as again, we'll talk about, I think in the lunch session today, they'll have some kind of crisis involvement with the police. They might end up in jail. They might end up in the emergency department. They might end up in the inpatient unit. And it's from usually the emergency department or the inpatient unit that they get referred to a coordinated specialty care program. And that, with the caveat being, assuming the coordinated specialty care program actually exists in the community in which that person's living. And what we find, which we know, is that with the longer duration of untreated psychosis, the more trauma that individual's undergoing, and the longer the delays in care, the less effective that care is going to be. And what we're starting to learn through other studies, in addition to RAISE, is that it's actually gaps in our own treatment system that are causing the delays. So it's once that individual reaches out to the physician or the school counselor, it's then finding the right program for them that's actually causing the delay in the treatment seeking or the connection to the appropriate service. People don't know where to send them, and so they kind of linger in ineffective services, and that's what's causing these long durations of untreated psychosis or ineffective care. So with these kind of early intervention treatment models, the goal is to build referral networks. And instead of waiting for somebody to cycle through this whole system, there's more of an assertive community outreach approach where somebody on the treatment team, and it could be the team leader or it could be an outreach specialist, has the job of reaching out to the community and educating them not only about the coordinated specialty care program, but also about what individuals would be appropriate for that program. So the goal is to have more active community outreach in order to expedite referral into the program, so to facilitate referral to coordinated specialty care, to reduce DUP, and to improve overall engagement through this active outreach approach. So the RAISE projects really focused more on these proximal referral sources, so the places most likely to be identifying individuals with first episode psychosis. So there's a real coordination with inpatient units, emergency departments, and police services to kind of educate them about who would be appropriate for these sorts of treatment programs, and a very active ongoing engagement with those referral sources to get people as early as possible. You know, our future goals for next steps would be to focus more on primary care, school counselors, and more of this community-wide education approach around first episode psychosis and who might be appropriate for early intervention services. And again, the goal here is shorter DUP, less distress. So by having more active community outreach, you're decreasing duration of untreated psychosis, you're engaging people earlier in care, and then you've got that promise of better outcomes with early intervention. The other role of the team leader is to coordinate clinical services among the team members and provide ongoing clinical supervision to individuals on the team. So this is something that's also a little bit different from what you might typically see. Since this is a team-based approach, all providers receive training in the principles of phase-specific team-based care. So you might be the team prescriber, kind of delivering the medications, but you're also as educated in these underlying concepts of recovery-oriented care as everybody else on your team. So you might not be delivering that direct service, but it's really important that everybody on the team be on board with the same sort of a treatment model. So again, the recovery-oriented principles, the team-based care, and typically a lot of the programs educate their whole team in terms of approaches to substance use treatment, family engagement, involvement, and family psychoeducation. The team leader is responsible for ongoing supervision and/or consultation. So again, to monitor overall fidelity to the treatment model, the team leader is responsible for making sure everybody's on the same page. And there are weekly team meetings to improve coordination, quality of care, and making sure everybody's on the same page in terms of the treatment delivery model. So there's actually 2 levels of team meetings that occur with this sort of a treatment model. One is the team itself for ongoing consultation and supervision, and the second is with the individual in care and their team. So the way these models work is typically that participant in the program will have kind of one key point person on the treatment team that they interact with and helps coordinate their particular care program, but that individual will interact with the whole team as well. So there could be whole team meetings between, the supported employment specialist and the case manager and that individual who's seeking the service. So there's much more coordination with this kind of model than you might typically see in community mental health care. And also 24-hour phone coverage. So there's availability for crisis situations 24/7 with this kind of a treatment package, again with the goal being of trying to avoid either hospital stays or emergency department visits. And we hope that over time, program costs go down and the clinical benefits go up with this sort of a model. The other service I want to talk about that we find to be oh so important is supported employment and education services. So this is ongoing coaching and support. It's programs to help individuals understand and learn the skills necessary in order to go out and seek employment or seek education, stay in school, and then ongoing coaching and support once an individual is engaged in school or engaged in a job following their placement. And this is probably the one role that's an exception to what I said earlier about combining roles for this kind of a service package. Typically, the IPS specialist, the supported employment specialist, is pretty highly trained, and this is a really labor-intensive kind of a position. So typically, this individual doesn't take on other team responsibilities, but is focused much more heavily just on their role in supported employment and education. So I'm going to give myself one quick break and give you a quick break from listening to my voice. And I want to show you another video. This is Corey, another individual in recovery, talking about his experience with supported employment and education in his treatment.
Hello, my name is Corey. I'm 32 years old. I've been diagnosed with schizoaffective bipolar disorder since I was 19 years old. I was a high school basketball star from 93 to 97. I had a partial scholarship for Livingstone College, and I used to exercise with the school and the team, but I didn't get a chance to play not one game. The reason why I didn't get a chance to play not one game because I had a nervous breakdown. At that time, I did feel like the door was shutting on me as far as basketball. But I had to realize once doors close, new doors do open. And once new doors did open for me, I had to grasp it, and I knew I wanted it. So it was an all-day class. It got real intense at time when it's time to take them exams, so I had to go home early at night and leave my boys behind and go do some studying, go do some homework. It was like college all over again. But once I got in the swing of things, everything started to come natural. I began to get more interested in certain classes, the writing classes. I began to get more interested in learning how to write case notes. It felt very good, you know, accomplishment. You know, my support group, they helped me out a lot. They just gave me the advice on keep striving, Corey, you could do it. Don't sell yourself short. Don't settle for less. Be a productive member in society. Don't let a mental illness stop you from becoming successful. It's like the encouraging words they gave me was like, I didn't want to turn back. I wanted to do more. I wanted to become successful. The professionals, I feel they have insight on seeing a person's potential before the person can possibly see their own potential. And tell it to them, go ahead, you could do it. You know, just hearing that positive voice in the back of your mind, you could do it. You could do it, Corey. That's something to motivate you. Well, this key right here symbolizes me entering a new door after another door closed out on me. And it means a lot to me because I never thought another door would open for me after my basketball career came to an end. And once the new door opened for me, it was special.
I love his metaphor of the key and of opening doors and of exploring new avenues because I think it's a really important message of, you know, your trajectory might look a little bit different than what you had envisioned, but there's still promise and there's still paths you could take. So in both of the RAISE treatment studies, they included a supported employment and education component because they felt like it was really important. I think in talking to the investigators and looking at some of their data, I think everybody kind of underestimated how important this treatment element was going to be for the participants. It just ends up being probably one of the most valued services that is being provided as part of these treatment packages, and it's what engages people in treatment. It's being able to offer them a service that aligns with their goals. So the value of supported employment and education in the treatment package is it's meeting an individual with what their goals are. So it's engaging them in treatment by saying, what do you hope to achieve at the end of this? And oftentimes it is a return to school or it is a return to employment. So with the RAISE packages, you know, they offer all of the services that I've been talking about, but what they find is that the one that's most commonly selected by the participants is the supported employment. So in the large randomized controlled trial, 78% of the participants in their first year of treatment participated in supported employment. And in the other study, the RAISE Connection program, 94% of their participants chose to engage in supported employment and education services. So it just appears to be one of the factors that is the most engaging factor in treatment. And so what it does is it's the entry point. So you engage somebody in supported employment, you help them align with their goals, and then that allows you to kind of open the door to the conversation to all the other treatment services that are available, be it pharmacotherapy or be it individual therapy or involvement of the family. So just a really important take-home message for us has been that the availability of supported employment is boosting overall engagement and adherence with the rest of the coordinated specialty care model. And there's a trend for lower disability benefit use, so a lower need for Medicaid benefits or Social Security disability among clients with first episode psychosis who end up participating in supported employment and education services. So we're really kind of tackling what I talked to earlier about the high unemployment rates among individuals with schizophrenia and showing that with supported employment, first episode psychosis patients can have productive employment careers. This is just some data from some studies, not the RAISE study, but Clackey et al. Is Australian data, Nectarline is in UCLA. But what you see is that first episode psychosis patients respond to supported employment and education services. So I should explain that a lot of the data from supported employment was with chronic schizophrenia patients. It hadn't been adapted for first episode use, and there'd been less of a focus on supported education services. Since with chronic schizophrenia, you're dealing with an earlier population, the researchers have been working to figure out how do you adjust the model to help with education goals and education support, and also transition to college. So the Kalaki data, what you'll see, this is an Australian model, but for individuals who participated in the vocational intervention, so again, the enhanced supported employment services, 85% of them were engaged in competitive employment or some form of a career course at the end of the study. The treatment as usual group, only 29% were able to engage in some form of a competitive employment or course. The Nectarline data, which has been submitted for publication but hasn't been published yet, he looked at a first episode psychosis population, compared what's called the individual placement support model of supported employment, combined with a workplace fundamentals module. So this is vocational rehabilitation and social skills training. He compared it to just a standard of care, brokered vocational support. And what you see over time is that within the first 6 months, those individuals who participated in the individual placement support model, 83% of them were in competitive employment or school. And then what he did, which was different from the Kalaki study, was to look at sustained effects over time. So what you see is, 7 to 18 months out, those individuals, 92% of them are still engaged in some form of a competitive employment or school program. So the enhanced model can double the percent of patients with first episode psychosis who can return to competitive or work or school within 6 months of engaging in the treatment program. So we see that this kind of a treatment model is just incredibly, incredibly effective. But there's always a but. And those of you who work in community mental health care and our treatment providers might be saying, but Amy, how do we get this paid for? What do these services look like from a cost perspective? So as I said at the start, when we launched the RAISE project, one of our caveats was that the researchers couldn't use the study dollars to pay for services. So we kind of challenged them to say, come up with a way of getting this paid for using usual means of payment. And the two treatment study teams came up with 2 different ways of doing this. I'll spend some time on one, not so much the other. One of the treatment teams basically partnered with their state mental health associations, and the offices of state mental health gave them funds to help support the treatment program, because the state felt like it was that important to invest in this service, and that would be the Connection program, and they partnered with New York State and Maryland State. The other team basically looked towards usual means of payment and CPT codes to figure out how they can get these payments, how to get these services paid for, and we've got some data out in terms of what they were able to achieve. So psychotherapy, family therapy, pharmacotherapy, all standard CPT codes they were able to bill for and get their services paid for. Case management and supported employment and education ended up being a little bit harder to address. Basically, case management, some of the states and some of the clinics were able to get Medicaid waivers, but those of you who are familiar with Medicaid coverage of case management is it can be variable, and typically individuals need to be more chronically disabled in order to qualify for case management services. And supported employment and education also ended up being a challenge. So some of the clinics were able to cover the service through Medicaid waivers in terms of how they were using their state Medicaid dollars, but at the end of the day, they kind of needed to come back to us to say, we can't get this covered, nobody's willing to pay for supported employment, and we realize it's an invaluable tool. So we learned that it was variable coverage for case management and supported employment. And then this is probably not shocking to anybody in this room. It wasn't shocking to me as somebody who does have a history as a clinician. But those roles that are so important in terms of good care management, so talking to your colleagues and collaborating with the other members on your team to deliver appropriate care, was not covered. So, what we were saying was it's really important that you have care coordination and that the team members have dedicated time together, but the problem is, you're all subject to billing requirements and kind of covering your direct service hours, and this is indirect service, and indirect service is never paid for. So, it was a good kind of lesson to us, and this is, an area that we've been trying to take on at the NIMH, which is to help figure out on a policy level, how do we start to get some of these services paid for, because these are the key ingredients, and what we're finding is the key ingredients are not typically covered by usual means. So this is what the coverage looks like, and this is where the gaps are in the coverage, and I'm sure those of you who work in community mental health probably could have told this to the audience yourself, because this probably wasn't a surprise. So this is the question for us now: how do we close these reimbursement gaps, or where do we go from here? So, some would say that the 10 most frightening words in the English language are, we are the government and we're here to help, and sometimes that can be very scary. But there was a time, very in the not-so-distant past, where those were really good words for those of you who are interested in early intervention care for first episode psychosis. So back in January of 2014, when we finally got a budget, the Consolidated Appropriations Act of 2014 was signed. This is House Resolution 3547 at the 113th Congress. And this was kind of unprecedented for those of us in the mental health world, because what Congress did with this budget was they increased funding to SAMHSA through their mental health block grant program by about $25 million. And this was done in order to implement first episode psychosis treatment programs. So the key thing here was, oftentimes with budgets, you're told to do something, but you're not given money to do it. You have to reallocate. This was, states were being asked to do something, and they were given additional money to do it. So this was new money. This was new 5% set aside, added to the state block grant program in order to increase funding for evidence-based programs for first episode psychosis. And so what the legislation also did was it encouraged SAMHSA and NIMH to work in partnership together to come up with guidance for the states in terms of how to do this. So how could states implement some of these treatment programs that I've been spending time talking about this morning? So starting on January 18th, we had very regular meetings between the NIMH and SAMHSA to figure out a plan for implementing the coordinated specialty care model that I've been talking about on a national level. So it's been actually a very exciting time for us, and we're learning as we go in terms of how do you do something like this on a national scale. So we worked together with SAMHSA, and we came up with some guidelines about what constitutes evidence-based care for first episode psychosis. A lot of what I'm talking about today is summarized in a white paper that's available on our website, and I'm happy to share the link with you. And we've done a lot of work on the NIMH side to provide training to SAMHSA program officers to help them understand this kind of a treatment model. We've been participating in webinars sponsored by the National Association of State Mental Health Program Directors and the National Council of Behavioral Health. And currently, we're in the process of working with SAMHSA around providing technical assistance and ongoing training to states in terms of thinking through how to implement these kinds of treatment programs. So we came up with this plan. We briefed the Appropriations Committee about our plan in mid-April, and then everybody was kind of off and running and trying to get these dollars out the door because they were FY14 dollars, and we were already pretty much through FY14 by the time we all learned about this. So the funds from the block grants can be used in lots of different ways. They can be used to develop new programs where there aren't any. So if a state doesn't have any coordinated specialty care for first episode psychosis treatment models, they can use their funds to start to set up a new treatment program. Or they could use to supplement or enhance those programs where they already exist. So a lot of the states are using the funds where they might have kind of the core elements of this kind of a program, but they can't typically get supported employment paid for. So they're going to use their funds to pay for supported employment, or to pay for case management, or to pay for some of the team coordination that aren't kind of the typically covered services. So it's been a really exciting time. We've been learning a lot as we've been doing this, but kind of from the mental health side, it's really been a unique and exciting opportunity to be able to kind of disseminate evidence-based care on this national scale and to be given funds in order to be able to do it, instead of telling states, oh, no, you have to stop one program in order to start this one, but that this is kind of in addition to what states are already doing. So what benefits can we expect if coordinated specialty care is implemented broadly once we get widespread dissemination? Well, one of the outcomes we're hoping for are lower rates of hospitalization. So this is some data from abroad. So Bird in 2010 published a summary of studies from programs that were implemented in the UK, so the LEO project, the OPUS project, the COAST project, and what they found was that individuals who participate in usual care in their first episode psychosis, about 42% end up back in the hospital. For those who participate in coordinated specialty care clinics, about 28% are rehospitalized. So again, this promise of decreased hospitalization rates for individuals in their first episode of psychosis. And this is some data from the US, which looks equally promising. So Nectarline Ventura using off of all published studies where we see rehospitalization rates for individuals participating in these sorts of treatment programs anywhere from 17 to 27%. The data from the RAISE project is not available yet, but we're hoping it's going to look about this rate as well. So decreased rates of hospitalization for individuals who participate in these sorts of treatment programs. The other thing we hope for are lower overall healthcare costs. This is an example, some data from an Australian program called EPIC, Early Psychosis Prevention and Intervention Center. It's a national program in Australia focused on early intervention for psychosis, very similar treatment package to what we're offering through our coordinated specialty care models. But you can see some of their data here. This project really served as one of the models for RAISE in terms of thinking about our treatment package. But what you find is that total mean mental health service costs per patient were about $48,000, that's Australian dollars, lower than control. And then what you see are the average costs of an EPIC patient per year and an average cost of a patient in usual care per year. And again, you see about a $6,000 difference in average cost per year for individuals who participate in these sorts of specialized treatment programs, as opposed to individuals who are just participating in services as usual. And over time, the group remains less costly to treat, and they tend to have a more favorable clinical outcome over time. So we have started to look at our own data through the RAISE project, and we've started internally at NIMH to do some cost effectiveness analyses to look at the per capita cost of typical care versus the per capita cost of specialty care. So looking at typical care minus specialty care as your net healthcare cost. And the bottom line is when we compare some Medicaid data, individuals' first episode psychosis in a Medicaid cohort, as compared to individuals in their first episode of care through our RAISE treatment projects, there's about a $3,000 difference in costs for the year over services per individual, and it's really driven by differences in service utilization. And that $3,000 is on the side of the Medicaid paying more than the first episode specialty care program. So what we're finding is that even though you're kind of paying for more with the coordinated specialty care in terms of the team coordination, the supported employment specialist, and maybe some staff time, you're paying for less on the side of the more expensive services, which is the psychiatric rehospitalizations. So by paying for less costly services, overall the treatment package looks more cost effective over time. So we're hoping that one of the early papers to come out of the RAISE study will be their cost effectiveness paper, so we can really start to document that over time there might be lower costs associated with this sort of coordinated model than your standard of care. And again, that lower cost is coming by reducing things like inpatient hospitalizations and putting more of your dollars towards outpatient care and the staff time needed for the team coordination. So for the NIMH, in terms of where do we go from here, well, there's going to be this national rollout of coordinated specialty care programs, and we'd like to study it and study the implementation and figure out how to evaluate it, so to look at outcomes on a national level as more and more states start to implement coordinated specialty care programs in community clinics. We're trying to develop, test, and implement strategies for reducing the duration of untreated psychosis. So last year, we funded a whole series of new grants that are targeting duration of untreated psychosis to kind of better understand this phenomena in the United States and to come up with more effective strategies for engaging individuals in care earlier on. So we're focused on a national level at trying to figure out why it takes so long for individuals to get into care and come up with interventions to try and reduce those delays. And then our most recent effort is focused here, kind of in the prodromal phase. So to test clinical staging and stepped care models for interventions with people at high risk for psychosis. So, we've got the RAISE project, which was squarely focused on first episode care, and now we're moving a little bit earlier on in the course of illness to see what we could do for individuals who are at clinical high risk to prevent the transition to psychosis. So we just funded, I think, about 6 to 8 grants in the last 2 weeks that are all focused on different forms of intervention for individuals who are at clinical high risk but have not yet experienced their first kind of full-blown psychotic episode. So again, trying to move that promise of prevention even earlier on in the course of illness. So I'll end with just a screenshot of our RAISE website, which was recently updated. And if you go to the RAISE website, I think the slides were available to download, so you should be able to find these links. But you can access a lot of the resources that I've been talking about today. So what we did on our side, once the state mental health block grant funds came in and states were going to have to implement a lot of these programs, is we made all of the resources available from the RAISE study freely available online and downloadable. So if you go to this website, you will see the treatment model that I've been talking about, so evidence-based treatments for first episode psychosis, that's our white paper. But you can also have access to actual treatment manuals that were used in the study. So there were 2 treatment teams. We've got 2 sets of treatment manuals. We've got implementation manuals, so kind of the how-to of how to set up these sorts of clinics, how to set up referral networks, how to train individuals. The manual and program resources from an On Track New York program, which has the Voices of Recovery video series, all available online for you to access, as well as the manuals. So there's lots of resources available to you. I encourage you to look at them at your leisure and see what might be helpful to you in your own practice as you deal with this population over time. And there's my contact information. If you've got any questions after I have to leave your wonderful state, feel free to follow up with me. I'm always happy to talk about these sorts of programs. So I'll stop there, and I think we might have some time for some questions. Mics. Oh, there's mics here and there. I think if anybody has any questions for me.
This is fabulous. I guess my question again is, in practice, it sort of sounds like people are coming to get these services, but in practice, a lot of times is that the person in their psychotic state isn't recognizing their illness, so it's the family calling, it's other people calling, and so where does that fit into the studies and the work you guys are doing?
The families are a key component, and they found that oftentimes the initial contact point is not the individual, it's their family. Because these were research treatment studies, ultimately it had to be the participant who came in to care. But I think what they find to be most engaging, especially with somebody who doesn't want to acknowledge that they have an illness, is to focus on their goals. So to not make it about the illness and not make it about treatment, but make it about the end game in terms of, what do you want to achieve and how might we help you achieve that goal? So I think, kind of getting the family on board with that kind of messaging and getting the individual on board with that. No, it's not about treatment. It's not about chronic illness, but kind of getting that out of the language. And there was actually a lot of debate early on in the projects about even calling it Schizophrenia Project, because they didn't want even that to be a deterrent, especially, again, because you're dealing with such a young population that doesn't believe they have an illness, that I think that's kind of less of the conversation. And it's more about there are things that are going on that are interfering with your capacity to go to school or get a job. How can we work with you around that? And then you kind of bring the treatment in later.
How many patients or clients does each team have?
Average caseload is about 20 to 25.
Per team?
Per team is what they're finding is manageable.
I'm Catherine Clammer with the Oklahoma Department of Rehabilitation Services, and we have supported employment that we fund. So anyone with schizophrenia who's in treatment can receive job coaching for competitive employment. We don't currently have it for job coach services for people who are in school, but now that I've heard this, I'll go back to the agency. We have an innovations department and see what could be done. I was just wondering, did Voc Rehab do they not have support employment? You said you had trouble finding that service.
Financing it.
Financing it. Voc Rehab pays for that. Does that
so
not happen
I think, you know what, you're going to tax me on kind of understanding the nuances of all the different clinics, but what we were finding was that each clinic in each state had different ways that they could get that paid for.
Okay.
So it was a state by state, or at least kind of the states that participated in the project.
Okay.
There was a study commissioned by the Assistant Secretary for Planning and Evaluation that did a more in-depth study of the financing of the RAISE models, and what they were seeing was there was tremendous variability according to how each state set up their services around the supported employment and voc rehab.
Well, in Oklahoma, if you have someone that with schizophrenia who's in treatment, they can get supported employment for competitive employment by coming to vocational rehabilitation.
Great, thanks. Great. More questions? Sure.
I'm also with the Department of Vocational Rehab. I was wondering how many hours are required for the supported employment? How intense is it? Do you know?
I don't know off the top of my head, but I can find out for you. I'm sorry.
I'm wondering if you could comment on the early diagnosis in the prodromal stages in adolescence. There's so much overlap in symptoms at that age. If you're going to intervene there, how do you do that?
I think that's a really great question. I'm a child psychologist by training, and differential diagnosis in general is so challenging for child and adolescent mental health. Right now, I think a lot of the work is in kind of the research diagnostic phase. So there are structured interviews for prodromal syndrome, so SIPS. It's kind of a research diagnostic criteria where there's a certain number of psychotic symptoms and a certain degree of the symptoms, and an individual has to kind of meet certain cutoffs for those numbers of symptoms and kind of intensity of symptoms in order to qualify for these treatment studies. I think you raise a really interesting point, which is kind of how to take some of what's being done in the prodromal space and move it into the community setting, because that hasn't really been done yet. I think a lot of the work on the schizophrenia prodrome has really been more in kind of the academic medical centers and kind of specialized clinics, and I don't think they're at the point yet of being able to have tools to take it out into the community to help, for example, a school mental health provider differentiate, what's kind of early schizophrenia versus adolescence versus bipolar disorder versus kind of the amalgam of what you could see. But I think that's the direction that it's going to go in. So, as I mentioned, a lot of the work has been done in kind of proximal referral sources, but not yet moved into how do you educate school mental health clinicians, for example, on this differential diagnosis, because I think it's a challenging one.
Are there significant differences in the use of medication in this model?
Significant differences in medication?
Differences in types of medication or levels of medication?
So for the RAISE studies, there were two, each study team tested a different treatment algorithm for medication. I don't know the algorithm off the top of my head, but I can tell you that the basic theme was one medication to start at a lower dose than is typically seen with schizophrenia. So they had kind of their algorithms for what medication they would start with, and then over time would potentially increase. And the medication was also done in a shared decision-making framework. So it was a conversation between the individual and the provider in terms of whether or not medication was even included as part of the treatment package. But information about the specific algorithms can be found in the treatment manuals. Great, well, thank you for your time. It's been wonderful to be here.
Wow, guys, I've been doing this a long time. This stuff is transformative. This is a big deal. I think this is the future. We need to really, I think we need to really go and study and look at this, the RAISE project very carefully and be thinking about it. I know, talking to Terry, John Hudgens over here, the Department of Health and Substance Services, they are on board with it. They are implementing it. We need to get on board with it in our communities. It's really, really a big deal. Dr. Goldstein, thank you so much for bringing that and coming out, and welcome to Oklahoma. There's a few little housekeeping things I got to mention to you all. First of all, we'd like to say thank you to Family and Children's Services for sponsoring our coffee break this morning. Coffee stations can be found in the ballroom gallery. I think everybody's kind of looks like they've found those pretty much. And please enjoy that. And when you see our friends from Family and Children's Services, pat them on the back and tell them thank you very much. We want you to remember our breakouts start at 10:20. We have a good number of options for you this morning, and we look forward to you. Again, they're asking us to clear out the ballroom because they're going to turn this and get it ready for our lunch noontime plenary. So you can help us there with gathering all your things up and moving into the reception area out here. And again, I just want to thank everybody. And again, let's give Dr. Goldstein one more time. Give her a hand. Thank you.